Hello, kidney warriors. James here with Dadvice TV, your online kidney health coach. And this is another episode of Dadvice TV Live, empowering you with information to help you improve your quality of life and live longer. And tonight we have back our favorite. You guys ask for him all the time. I hear you guys like, oh, when's Dr. Rowe coming back? We have Dr. Rosansky back, who is the author of Learn the Facts About Kidney Disease. Matter of fact, where's my little picture of that book? Right here it is. Boom. It's a little zoomed in. But this is the best book out there for understanding kidney disease, what you need to know about it, when you should worry, when you shouldn't. And he's working on another book that will be coming out very soon. That's about living longer, the things you can do. So it's more than just about kidney disease. And I am so excited. Him and I were just talking behind the scenes about his new book. I'll let you guys know as soon as it's available and have a link so you guys can order it, but it is going to be great. Hello, Jennifer there. Great to see we got a lot of people. Good evening. All right, let me go ahead and bring on my co-host. You know him, you love him, Dr. Steven Rosansky. Hey, Doc, how you doing?
I'm good, James. I'm good. I'm excited about tonight's show. And the topic is one that so many of our friends and all around us are kind of obsessed about. I've got some really interesting new information about weight loss drugs, how they connect to kidneys as well. And I guess, James, you'd like me to introduce myself because there may be some new people out there. So I am
Yep.
a retired kidney specialist, nephrologist. I've also practiced internal medicine and nephrology. It's about 50 years. I still see patients in the free clinic, and I'm very excited to share with you folks my new book because it's got a lot of just useful information about what really matters if you want to live a healthy life, a longer life. There's all kinds of, as James and I have said on this show many times, woo woo out there. And people are buying stuff that is either not going to help or a lot of stuff that can harm. So I try to take that fear away about what it's going to be like to get older. And interestingly, James, there was a recent study that people assume, hey, I'm going to get to be older and I'm going to go downhill. But guess what? Almost half of the people that they studied got better with age. Their mental
Hey,
function, their physical function actually, so it is not impossible. So I think that's
well,
some real
I'll
exciting
tell you,
stuff.
there's a guy on YouTube who interviews people who are 80s, 90s, sometimes even 100 plus years old. And he talks to them, and some of them have more energy than me. And I think I have a lot of energy. So I know it's all over the place. And I am certainly interested in doing everything I can to stay as active and as healthy as possible for as long as I can.
Yeah, and I'm going to give you guys some good advice tonight. On one of the sections, I have a large chapter on weight, and I get into GLP-1 drugs, and we're going to get into that tonight. And again, in addition to being a retired kidney specialist, I've also done a lot of my own research. And James knows, and other people that have watched the show, that my research has been recognized by my colleagues around the world, especially regarding when to start dialysis, which I have hopefully gotten some of you folks to avoid unnecessary dialysis. And I've gotten other of you folks watching James' show to realize that you probably don't have anything to worry about with your kidneys because you probably have early, if any, kidney disease, and maybe not even any, which we've discussed, and likely that it will not progress. So we're going to talk about the GLP-1 weight loss drugs, but I'm going to tell you about drugs that I don't think James necessarily has heard of, and a lot of you haven't heard of. So let's get right down to it. James, you ready? Because we got a
I am
lot.
ready. Listen, and remember, everybody out there, I started in February the new Wegovy pill. I am on one of those GLP-1s, paying a fortune, $300 a month for it with the discount card from the manufacturer. and I'm only up to the half dose. I'm almost to the full dose, but they're taking the full amount out of my wallet.
All right, and I'm going to say this, and I'm going to repeat it, and it's worth repeating, and I'm going to tell James right off the bat, and anybody else listening to the show, if you are just looking for the pill to do the trick, and you're going to hear more about this, you are wasting your time, you are wasting your money. Hear that. If you're only going to do with the pill, and we're going to talk about this in detail, you're wasting your time and you're wasting your money. And I'm going to tell you how to get the right drugs for you cheaper and other cheaper options. And why did I say that, James? I hope I've made my point to you. Why did I just say what I said?
Well, we want to. Oh, first of all, everyone needs to save money because it's complicated and it's hard to figure out, and your insurance ain't covering it.
But what about what I said about if only you're doing the pills?
Yeah, the pill alone. And my doctor told me that. They said if all you're going to do is take the pill and change nothing, you're not going to, you know, adjust your eating, which is much easier with the pill for me, and you're not going to be active, it's not going to work for you. You still got to exercise, you still got to do everything. It's not a magic pill, it's a tool to help.
And we're going to go back over that in a few minutes. So I want to say that right up front. So these are exciting drugs. Some of you may have heard about, when I was a kid, there was a weight loss drug. I don't know if you heard about it in your younger years. It was this drug that people took when they wanted to stay awake for an exam. It's called Phentermine. It's a speed drug, you know. I mean, this is not even the Ritalin ADD drug. This was a weight loss drug that was a controlled substance. And it was the most widely used weight loss drug called Phentermine. And it was cheap, like $10 a month. But it's only good to use short term. And we're going to get into in a minute. But there is a drug which has got a weird name, Qsymia. Qsymia, all right? This is a combination of that old short-acting speed, phentermine, and another drug, topiramate. And this drug is also cheap. So there are alternatives. I'm going to tell you why they may be important for some of you out there. But these drugs are like 60 to 90 bucks a month. They're generic. Yeah. So that's something we're going to talk about tonight. So that's Qsymia. I think it's called Qsymia. I don't know why they picked such a weird name.
Yeah, they need to give it an easier to pronounce name so people can order it.
Well, the other drug, and that drug, so the weight loss drugs can give you, you guys know, 15 to 20% body weight loss. That's best case, and it's going to be a range. But that Qsymia, 10%, not bad, okay? Not as good, but it's got its place. And then there's another drug, and this is an easy one. It's called Contrave.
Oh, there we go. Much easier.
Contrave. And that one is also cheap, 30 to 60 bucks a month. And they have their place, and I'm going to talk to you where their place is. Now, Contrave doesn't give you quite the weight loss as the combination speed drug, the phentermine and topiramate, the Qsymia. It gives maybe 7% weight loss, but they have a specific place, and we're going to get into the types of weight issues that you may have. The current state of the art, ladies and gentlemen, is that the centers around the country that are up to date and doing the best work on this have described certain descriptive types of obesity patients. And just to give you, so you've got those two I just told you, two types, not new, they've been around for a good while. The GLP-1s can give you 15 to 20% weight loss theoretically with the injections, and not quite the same with the pills, about 12 to 16. But here's the latest way to look at how these different types of drugs are used. There's something, okay, again, this is in the top centers in the country that are treating obese patients.
Mm-hmm.
The first one is the hungry brain, right? You are not satisfied. And I talked to a friend of mine, a very close friend, whose daughter had a bariatric surgery. And that's what she described. She's got this hungry brain. She's always hungry, even though she's had the amazing bariatric surgery. You guys know about that. You just really have a little bit of a pouch that you're feeding in your stomach. You just need more calories to be satisfied. And that drug that I just mentioned, Qsymia, is the drug that they recommend. It will reduce your appetite through that speed type drug. I do need to tell you the downsides. I'm going to tell you the downsides of all of these drugs.
I'm going to guess your heart.
Exactly. And James, you hit it. And this combination drug, which is pretty cheap, has not been approved in Europe, just what James said, because since it's one of these speed type drugs, it can raise blood pressure, raise heart rate, and for some people affect their sleep. The other thing, the combination can also give brain fog. So there are downsides to all these drugs, every drug you take. But if that's the issue, the hungry brain, you can't ever be satisfied, that may be the right drug. There's the hungry gut, which is everybody's favorite, which is the GLP-1 thing. The GLP-1, you need, you feel hungry after you eat, and you need a lot of volume to fill you up. And the GLP-1 drugs slow the stomach emptying, and that's what will help the hungry gut. And the other thing that's recommended for these kinds of people is to eat a lot of protein and a lot of fiber. That'll get that stomach also to be blown up and to keep you from feeling hungry. Then there's the emotional eater, James, that we eat for comfort, for relieving stress, for coping. And there's a lot of people out there.
I think that was me.
A lot of people that have that. And the drug that I talked to you about, that second drug, the
Contrave.
Contrave, exactly. That Contrave drug, which is a combination. So the treatment for people that are emotional eaters, and you know who you are, is to go to get psychological help, cognitive behavioral therapy, figure out what the triggers are to get you to keep eating. And the combination drug, the Contrave drug that James just mentioned, has two drugs in it. It's got a antidepressant called bupropion, and it has a drug that will inhibit the opioid effect. So if you're on opioids, it's a dangerous drug because it can put you into opioid withdrawal. It also is not to be taken if you are a female with a possibility of pregnancy. It can cause fetal malformation. But it's a good one to consider with cognitive behavioral therapy if you are one of these emotional eaters. Then the last type, which is a real tough one, James, it's called the slow burner. That means your metabolism is slow, it's low. And here again, that first drug I talked about, the Qsymia, is a good drug because it's got that speed type thing in it to raise your basal metabolic rate. The other thing that's recommended for that type of obesity, and a lot of these experts are combining the drugs. They may put you on a GLP-1 with these other drugs. So it's getting to be a much more complicated approach to treating obesity. It used to be just, hey, diet and exercise, or, just take this drug or fast or whatever. Now there's a lot more options. The other thing you want to do if you are one of these people where your metabolism is slow is you've got to exercise and you've got to build muscle. That's for anybody. If you exercise and build muscle burns much more calories than any fat. Fat doesn't burn calories. So if you can produce more muscle, you're going to get rid of more calories. So, James, do you remember how the GLP-1 drugs work? Do you ever get the message on that one?
I know they were first a treatment for type 2 diabetes, and it's
Right.
a hormone that you release, and it either causes it or simulates it. Um, and for me, I can, my craving, my boredom eating has definitely gone away. And I proactively now have to remember, eat my meal, eat lunch, eat dinner. I don't eat breakfast. I just never have. But I have to proactively, and I always kind of feel nauseous a little bit. So I chew, I don't have any laying on my desk. I chew ginger chews throughout the day to address the nauseous. But that's what keeps me from wanting to eat and being hungry.
Well, you described a lot of things we're going to talk about, James. So, what James is describing is this drug, GLP-1, is an agonist, means it acts like something that's natural. That's what an agonist is. It's a GLP-1 receptor agonist, acts like the actual thing released from the gut when you eat called leptin. Leptin, okay, that's the thing that's released. And that leptin tells the brain, hey, I'm full. I'm not hungry anymore. But what happens is a lot of people that are overweight, that signal is not working. That leptin signal to tell the brain, hey, I got enough, and it's not working. And with the GLP-1, the brain now is getting the message that James just told you. I'm full. I don't need anything. And the cravings drop, what James just said. When we get that leptin to work on the brain, the cravings drop. And there is a downside that James didn't mention that a lot of people mention, and I will get back to this in a minute, especially for older folks like me. And I've got some of my contemporaries that I think wrongly have been taking this drug. You lose the pleasure of eating. And let me
Oh, yeah.
tell you, folks, there are few things for some older folks, and not for me. I mean, like a lot of older folks stay active and they get pleasure out of a lot. But one of the pleasures of life, let's face it, is eating.
Hmm.
So be prepared. You're going to lose that, and you got to, so you got to think if that's worth it. And the GLP-1s slow the emptying of the stomach, so you feel full longer. And as James said, it was just incidentally that they found that these diabetes drugs, these GLP-1 drugs, with diabetes drugs, they go, wow, look at how our diabetics are losing weight. And like all diabetes drugs, it gets insulin out, right, to lower your sugar, and it does something else. There's something called glucagon. Anybody who's diabetic knows what glucagon is, because some of you keep a little glucagon syringe. If your sugar goes down, you take a bolt of that and it raises the sugar. So the diabetes drug, the GLP-1s, suppress the glucagon. So it's not going to raise the sugar. So that's how they work. So let's get right down to the big players of the GLP-1 story. The first one is, this is the generic name. So there's brand and generic name. Generic name is semaglutide. And semaglutide to treat for diabetes. And this is crazy. You got the same drug at a certain dose, which is a lower dose used for diabetes. That's called Ozempic. And then you have the higher dose of the same drug called Wegovy.
That's what I'm on. Wegovy, but the pill.
That's the same drug at a higher dose. And the next big player is tirzepatide. And you folks are going to know it as Mounjaro for diabetes and Zepbound. This is the big one for obesity. And this drug targets two receptors. So it's an agonist for GLP-1, but also for something else called GIP. I won't tell you what it means, but that is also going to have the same effect. It decreases your cravings, and it decreases it even more, and maybe a little bit better weight loss with the Mounjaro and Zepbound, and maybe fewer side effects. But they both should be just fine. And James has been talking up the pills, okay? So let's look at the pills. James' pill that he's on, you're on the Wegovy pill.
Yep.
Came out just released December 2025, right? Hot off the press. And James is one of the early ones to get that drug. Good for him.
Let me tell you,
Right?
January 4th, it was available. And I called my doctor and said, hey, I want it. And she said, hey, make an appointment and let's talk first.
And Lilly's got one coming out. It already just came out in April this month. It's called Foundayo, Foundayo. And this drug is a real game changer. Let me tell you why. And James could tell us about this. To take the Wegovy pill, first of all, if you take a protein, that's what these drugs are. They're proteins made up of amino acids, right? If you take the Wegovy pill, you've got to take it first thing in the morning, because if you get food in your stomach, it's going to stimulate acid. Acid is what the stomach produces to break down food. Acid will break down that drug, the Wegovy pill. So that's why you've got to wait and only take it with a little bit of water. And
One
then you
sip
got
is all I do. It's up to 4 ounces, and I set my alarm for 5 a.m. to get up, take my sip, go back to bed, because you don't feel good that first hour after taking it. So I sleep through it now.
Wow, interesting.
Yeah.
Well, the other thing, James, you got to wait 30 minutes before you take it. But here's something which you may want to consider, and certainly everybody listening may want to consider. That's the Novo Nordisk pill is the Wegovy pill. Eli Lilly has and there's going to be enormous competition, you guys and girls. That Eli Lilly pill that just came out in April this year, we just got in April. This is a game changer. No fasting requirement, James. You could take it any time of the day. You could take it whether you eaten or not. And they brilliant. Somebody figured out how to keep it from breaking down with the acid. I don't know how they did it, but they did. So
That's actually because if I forget my pill, which I've only done that once, you can't take it. You got to wait till the next morning. You just skip that one.
I think that Lilly's pill, assuming it's going to be the same price, which my understanding it is, they're going to take it's a no-brainer. I mean, if you could take it anytime and you don't have to miss a pill because, like James just described, I think that it's going to be taking a lot of the business. But here is a biggie for all of you folks that watch this show and have heard me talk about cardiovascular disease. And all of you folks that have listened to James and me talking about why this whole CKD business, GFR business became such big stuff, because if you've got an abnormal kidney number, EGFR, it is a risk factor for cardiovascular disease, heart attacks and strokes. And unfortunately, the oral medicines have not been shown to provide the same benefits that these GLP-1 drugs provide as injections in terms of decreasing heart attacks, strokes, heart failure, and progression of kidney disease and kidney failure. Okay, they may do it, but we don't have the evidence. So if you're taking the pills, you got to be aware of that. My guess is that they'll be studied and they should provide the same benefits, but we don't know that. Maybe there's something about getting it in an injection that really makes the difference. Okay, what to expect?
I just couldn't come around to giving myself an injection. Now, my mom, diabetic until she had weight loss surgery and got off her diabetes, their insulin shots, and I would give her insulin shots, but I tried to give myself a shot, and I was like, nope, I can't. I'll just wait for the pill, and that's what I did.
Well, look, I mean, I get it, and there are a lot of people that would prefer it, but the injection is currently once a week, and I'll tell you now, it won't be long that there will be a once a month injection. Yeah, so that's coming down the road. There's a lot of stuff coming down the pipe. James probably told you how it affected him. It reduces your appetite, and James actually lost weight right away. People will lose some weight right in the beginning. On the average, folks lose about 10% of their body weight within the first 3 months. That's amazing. And you gradually, as James talked about, increasing the dose. Whether you're taking, and James told you, he's getting no side effects. And this is not necessarily all fun and games. And again, you're not going to enjoy eating, and you're going to be having nausea, vomiting, diarrhea. That's very, very common side effects. And there are other side effects like gallbladder, gallstones, and that's happening in about 1 in 40 people. And here's something that I can't emphasize enough, and we already started out by talking about it. Almost half, 40% of the people, this has been studied, that stop the drug, they gain about half their weight, half the weight they lost in the first, 6 to 12 months. They gain it back. And guess what? The weight, now a lot of you who have weight issues have tried diets. James has tried diets. And it turns out that you may be gaining the weight even faster than if you did the old story of diet and exercise, which is very, very upsetting. And all of the other things that may have happened to you, your blood pressure coming down, your cholesterol coming down, your blood sugar getting down. You stop the drug, all of those things are going to go away. So you got to build the right habits. And that's what my book hammers away at. And I talk about the lifestyle issues throughout my book that make an enormous difference in how long you live and how well you're going to live in your later years. You want to try, and this is one of the things that I spent a lot of time in the book about what's your exercise goal. You want to try, just try to walk. It's great exercise. If you can do 150 minutes of that a week, right? That's roughly half an hour, or 20 minutes 6 times a week, or roughly, that would be 120, or 30 minutes 5 times a week. And strength training, especially when you're losing weight, you're going to lose muscle. You need to go and exercise your muscles so your muscle mass will remain. Because losing your muscle mass is bad news for your overall health, your longevity, and your health span, your years of having good health. And it has to do with the reset after taking these pills, but you're going to gain the weight back.
See, I'll tell you, I can see that happening if you don't make good habits, because right now I have no interest in eating. And I actually noticed food is far less enjoyable. Like at work, I don't want to snack on anything. It's like, I have no desire whatsoever. But I could see if I stop, or the day comes when I stop, because I'm not going to pay this much forever. I've got to have those good habits. Otherwise, I could quickly fall into food tastes good again, and I'm hungry and overeating, and then cutting back on exercise. Right now, my doctor said everything you said: exercise, weights, do things, keep my muscle mass up, because all that is really, really important while on these medications.
And people don't. There's a lot of reasons why people stop them. Roughly half of you folks that start them are going to stop them. So you got to be aware of the downsides. Some of it's because the side effects, those GI side effects. A big one is, as James just said, can't afford it. This is an expensive proposition for long term, especially with inflation issues. And as I'm going to spend a little bit of extra time on, for older folks, they're more likely to stop it. And we're going to talk about why in a minute. And especially early in the treatment, a lot of people start having abdominal pain, GERD, reflux, diarrhea, vomiting, and they just give up. And like I said, gallstones are not that common. 1 in 40 people have it. And I don't know whether you had this. Some doctors look to see if you have any evidence of gallstones before you start.
Oh, my gallbladder was removed a long time ago.
Gotcha. Okay.
The most painful thing I've ever experienced was my gallbladder, and
When
it
you had
was
gallstones,
bad. Yeah,
you had an attack. You had an attack. Wow. Yeah.
yeah.
Oh, okay. Yeah. So you don't want to have that happen to you, but it's one of the side effects. And you get, which James doesn't have yet, the Ozempic face.
Oh, yeah, I got my muscles still. I haven't gotten it yet. There's a lot of padding here. I got a long way to go before that can happen to me.
You get
But I've
this,
seen it.
oh yeah, I mean you get this. It really ages you, and that's why again, my contemporaries taking this drug. Are you kidding me? You're losing your muscle. You look gaunt. You're not enjoying. Anyway, okay, Okay, I'm going to get to that in just a minute. So, muscle loss is a huge problem because when you lose weight, about a quarter of that is your muscle mass. You're not just losing fat. And and as you know, and if any of you have heard a lot of my shows, we talk about something called sarcopenia, which is a Latin term meaning losing muscle. It is common after age 30, you start losing your muscle mass. And the only way to counter it is by doing exercises, weight-bearing exercises. And you've got to do that if you want to be successful. You got to combine the drugs with the right diet, the right foods, right? My book, we talk a lot about the Mediterranean diet, which is the #1 diet recommended across World Health Organizations and various dietary, cardiac, endocrine organizations, the Mediterranean diet. And we'll talk about that on another show. So you want to do resistance training. You can use bands, you can use weights, you can do planks. There's all kinds of ways, and I go through a lot of that in my new book. And now I give special warning for older adults. Let's say, and James always says, who's older?
Exactly. Who's older? I get a senior discount when I take the kids to Culver, and I don't consider myself older.
Well, it's hard to say. I would say roughly 65. But, some people are old at 50. Some people are not old until they're 90, At any rate, people over 65 are more likely to have the persistent nausea, vomiting, and diarrhea. And what can happen if you get nausea, vomiting, diarrhea regarding kidney patients?
I'm going to guess dehydration.
Absolutely. Huge. Big, big, big problem, which leads to a decline in kidney function. Mm-hmm. And it needs to be reversed by getting adequate hydration. And you're also thinning out your bones. Some of the loss is coming from the bones as well as the muscle. That leads to thin bones, which can lead to fractures, falls, and decreased mobility. So I'm not a big fan of this for older folks. I mean, there are some exceptions, and again, this is another thing I get into. I get into a lot of detail, James, about muscle, bones, and joints. My book has chapters on every organ system of the body, how they change with age, and what you can do about these changes. And I'm sure you have lots of friends, family members that have had joint replacement or have severe joint problems. And there is a possibility, if you're having bad knee, hip pain, losing 15% of your body weight or more, that can delay or avoid surgery. So that's a bona fide reason. And then you got to weigh the risk benefit of how much weight you're losing and whether or not the surgery makes sense. And that's a whole long discussion. And again, You lose the social interaction with food, which is massive. I mean, my kids were here. I've got 5 kids, and 4 of them were here for the holiday. And so much is food. So much of the interaction is food, whether we're going out to eat or having dinners at home. You're going to miss some of that out and miss the enjoyment of food. I'm not saying no one should take these drugs, but take them with eyes wide open. Understand what you're doing and what you need to do to be successful. It ain't going to work just taking a pill. You got to combine it with exercise and the right diet. And if you're not going to commit to it, like I said in the get-go, you're fooling yourself, because you may lose some weight, but you're going to gain it back. And you're going to waste a lot of money. Okay, there are other benefits of these drugs. And at the beginning of the show, we talked about the other 2 drugs, the unpronounceable Zymia, Xymia, and the what did I say? Contrave.
Hold on, I'm scrolling back. Hold on. Contrave.
Contrave. Yeah. So those drugs do not have these benefits. They may have the special benefits for the types of weight problems that we described earlier, but the GLP-1s have this amazing thing that we've discovered, just like the SGLT2s. So all of you with kidney disease know about the SGLT2. They are the second line of drugs that you want to take to protect your kidneys after the first line of drugs, which we say every show, which is the what?
The ACEs and ARBs. Those are drugs that end in pril and tan. They're very common and very affordable.
That's the first drug that almost everybody's got hypertension. They're great antihypertensives. They're also great for the heart. They're great to slow kidney decline, decrease protein in the urine. The next one is the SGLT2s, okay? Deflozins, empagliflozin, canagliflozin. And then after that, you've got the GLP-1s. Now, some people are pushing the mineralocorticoid type drugs like spironolactone, and there's a real expensive one, which I'm not a big fan of, for as layering drugs for people with abnormal EGFRs that also have protein in the urine. And this drug has been shown, one trial, there's going to be a lot more trials of GLP-1s for slowing kidney decline. It's going to be another addition to a drug that could be. So James, you're taking it for several reasons. You got the cardiovascular benefit, although it's a pill, we don't know for sure. Like I said earlier, there's no research showing that the pills have the same benefit as the injections. And all the things I'm saying about these surprising benefits that came out in this diabetes drug that wound up being this remarkable weight loss drug, but it's got all these other benefits proven with the injections. Let's be clear. So it decreases the risk of heart attack, strokes, heart failure. And because of that, it has been approved for people with obesity who have had a heart attack or a stroke. So or has chest pain. So if you're one of those people, your insurance should cover it. Insurance always gives you a hard time. You need pre-authorization, but it is an approved use of the GLP-1 injection, right? If you've already had a stroke, heart attack, or have chest pain and angina, because it's been proven to be beneficial. And the FLOW trial just said using semaglutide, this was in diabetics with CKD. So that's also covered by Medicare under Part D. I learned more about cost of drugs than I ever wanted to learn for this talk. I don't have Medicare Part B or D or anything, because I work for the government, VA, so I still have Blue Cross Blue Shield. But if you pay for the Medicare drug plan, Part D, and you are diabetic with kidney disease, Medicare should pay. How much to pay, and we'll get into it in a minute, blah, blah, blah. The co-pays, we'll get into that in a minute. And private insurance should cover it too. It should cover your diabetic CKD with pre-authorization. Okay. So these are surprising. We didn't know that this drug was going to do anything besides treat diabetes. Is something called fatty liver disease. Now, I'm not sure that's also become a covered diagnosis for these drugs. How they prove you've got that, it's kind of hard to prove without a biopsy. I'm not sure what they're requiring. But if your doctor has told you you've got fatty liver disease and you're obese, you may be able to get the drug as part of your insurance. This has nothing to do with an indication, but it turns out in a study of over 100 million people with type 2 diabetes that were on the GLP-1s, they had a much lower risk of colon cancer. How do you like that?
That's a nice bonus.
There are going to be more and more things that we're going to find out about these types of drugs. And then here's another indication. I think you may have this, James. Sleep apnea. It is absolutely approved through Medicare if you've got sleep apnea, obstructive sleep apnea. So these are things that that you should be able to get it through your insurance or through Medicare. And in terms of the cost, which has been an enormous problem. Let me just take a drink.
And I'll tell you what you're drinking. I'm not sure if I have sleep apnea, but I have. My wife definitely gets very upset at me at night and jabs me a lot because I snore excessively loud. Sometimes I wake myself up, and sometimes I get myself a sore throat. And she says that sometimes I just stop, and then there's a gap, and then I just suddenly start breathing again very loudly. So well, I may have it. It's never been tested for it.
Okay, this again is a plug in my book. I get into every system. I get into the sleep apnea diagnosis. And what James just said, and any other folks listening to our show tonight, James, you need to get a sleep study because it sounds like you may well have what he just described, heavy snoring, episodes where his wife noticed there's stopping the breathing. It is again, now you say you're getting your GLP-1 for what indication? Is it being covered? No,
it is not covered. I use a discount card from the manufacturer that drops the price from like $1,800 to $299 a month.
Okay, but even aside from this GLP-1 story, you should get it tested, and you may have a bona fide indication if you happen to have sleep apnea. How that's going to affect the pricing, this is way complicated. We'll get into that in a minute. But yeah, you should, anyone out there that has what James just described, and I would encourage you to have a sleep study. Okay? Let me know.
This doesn't sound convenient.
Huh?
I'm being honest. That doesn't sound convenient because that's where you go there and sleep, right?
Yeah. And well, actually, I think they can send you home with the equipment.
That would be doable.
I think they can send you home with the equipment to do the remotely do the sleep study.
My bed is extremely comfortable. When I travel, I have trouble finding a comfortable bed. It's like a rock, and I love it. It's so firm. My wife, her side has all these cushions on it for her. Mine, super solid.
Well, it's interesting, James, because my wife hates the bed I bought because she says it's like sleeping on a rock on a stone because it's really firm. I like it really firm. Anyway.
Yep. Same here.
Yeah. So like we talked earlier, these pills are going to come fast and furious. Right now, we got Lilly and Novo Nordisk. Everybody wants to get their GLP-1 pill, and the price should get to be around $150 a month in the future. And like I said, we're going to see once a month injectables in the future. So the list price of the injection is about $1,000. And there's all kinds of deals. I mean, enormous numbers of deals. And there's the people that are making the pill, they're trying to get you to buy their pill, and they're giving you like a teaser for the $150 a month. But you could probably get it directly from the company for in the 300 range a month. And you can get it direct to consumer. And some of the programs that are out there, you got to look them up online. There's tons of them. They also help you get the lifestyle issues. They deal with some of the psychological issues. So you can pick a program that you think will suit you. But again, I can't emphasize enough, just taking the pill is not going to do it. You're wasting your time and money. You got to commit to combining it with a diet and a lifestyle of exercise. So if you're type 2 diabetic, these drugs are out there for diabetes. So you should be able to get the drug. And as we said, if you've got documented heart attack or stroke or chest pain, angina, you should be able to get it. It's called heart disease prevention, but you already have to have a diagnosis, or sleep apnea. So these are things that insurance should be possible to get it paid for. The Wegovy injection, like I said, 2024, it became covered because of the study. All right, so those are the things that it will be paid for. And the problem with the new stuff coming out under Part D, and our president likes to say it's his baby, but it's a lot more hype than it is really a great deal. The problem is that it may be covered in Part D, but there's all kinds of catches to it. It may not go towards your deductible. You may have coinsurance, depending upon how much you're paying for your plan. The coinsurance can be more than you could get it if you deal directly with the company. So you've got to shop around, and they're talking about in 2027 having this Part D Medicare coverage become more prevalent, but your doctor has to get it approved, prior authorization. And it's crazy. They've got BMI, which is, BMI is your weight divided by your height square. So it's like you have to have a high BMI, you have to have something called pre-diabetes, or you got to have some kind of cardiovascular disease. I mean, the menu is complicated, and a lot of doctors are not going to want to bother with it. I think from what I can gather, and maybe James can advise you better than I can, look for the direct-to-consumer options.
That's what I did.
I don't know that the insurance companies are trying their best to not have to pay for this because it's a huge expense, and they're trying to avoid getting saddled with this huge expense. And Medicaid is not often covered, and there's something that we talked about a good while ago. Remember when they ran out of the drug, was so popular they couldn't make it fast enough, and they let your pharmacy do something called compounding. They make a variant of the drug. The problem is these are not FDA approved, and it turns out that the FDA has gotten a lot of adverse reactions from these compounded GLP-1 alternatives. So I don't recommend that you get them. And they're getting to be a lot cheaper. I mean, at a minimum, you could probably get it for, James is lucky. He got what yours costing you, 150, 200 a month?
The first 2 months, it was $49 a month. Then it jumped to $299.
Yeah. So if you're able to come up with $300 a month, you don't have to deal with any of the insurance BS. because the insurance BS may wind up being close to that. Look around, see what your insurance company is going to offer and what your doctor can do to get you covered. And James, I'm going to take a few minutes for questions. We got about 10 minutes if you want to pick any
Yeah,
questions.
and I'll share one more thing about my experience with the GLP-1. My doctor, pretty much everything you said, that was our original conversation.
Yeah.
This is not a quick fix. You got to change how you eat. You got to exercise, muscle. You're going to have to eat protein to make sure you're getting it. You're not going to feel well. Let me know. And every month, her and I do a telephone call, and I tell her how I'm feeling, and then she writes me the next 30-day prescription. So I'm on a 30-day at a time, and she's checking in. And she even told me a lot of people don't make it. They don't like it and they stop it, especially when they're paying out of pocket for it. Now we have a great question right here from Johnny, which I like, which is related to all of this. Um, is there a certain GFR where you recommend starting a GLP-1 or not? Is there a GFR, I'm going to add to it, a GFR where you shouldn't consider a GLP-1? Are there any dips in your kidney function?
Yeah. Well, look, I don't think I know they've been studied with moderate CKD, and they've been studied certainly with that. And well, as opposed to the SGLT2 drugs, the gliflozins, canagliflozin, epagliflozin, we talked, those are enormously powerful, great kidney drugs, heart drugs, decrease your risk of dying from heart failure, heart attacks, strokes. The GLP-1s have not gotten the same research. We got that one study that showed that they do something similar, but it hasn't been studied at very low levels of kidney function. And again, you're taking the drugs for their potential to decrease your risk of dying, not from kidney failure necessarily, but from other things. But I don't think we've got enough information on these drugs with advanced CKD, so I don't think it's out there yet.
Yeah. And for mine, my doctor had me get my labs before starting it. I was at a 34. I started it, plus my doctor's working on reducing some of my medications. So there was a medication that I cut back on, one that I stopped taking. And after 2.5 months on the GLP-1, still at a 34, which is great. And we saw some other positive signs that he believes are from reducing some of the other medications. One was my calcium went down because it was getting high, and there was one of the medications he says could cause that high calcium. So I'm looking good and keeping an eye on my labs.
Well, here's the thing that we should mention regarding your blood pressure and your blood sugar. When you take these GLP, well, first of all, they help control your blood sugar. And with weight loss, and one of my chapters in the book is how to reverse diabetes, a very important thing. There are a lot of people that can have their diabetes reversed in today's world. But these drugs with 15, 20% weight loss, your blood pressure may be normalized. You may not need blood pressure medicines. Your diabetes may go away, but again, it will come back if you stop the drug. So this is a commitment of lifestyle and drugs. And somebody saying that their sleep apnea went away, and my son-in-law had the same issue. Sleep apnea, lost the weight, gone. So if you do have it, James, it may improve with your weight loss.
Hey, that'd be fantastic. See a question you want to answer in there?
Okay. A lot of sleep apnea. A lot of people are really good at
People
home.
were saying, James, you can do it at home. Do it. So I'm going to talk to my doctor about it. See what we can do here at home, because I love my bed, and it's just, I just couldn't imagine actually getting a good night's sleep. And I love my sleep.
Yeah, yeah. Well, again, I think if you're going to take the drug, you've got to do it with eyes wide open. You've got to realize that there are other drugs out there that may be right for you, and you should at least consider the drugs we talked about earlier. And you need to get into a good diet and exercise program. And If you're if you're wanting to lose weight, I think what makes the most sense is start out getting the right habits. And once you've got the right habits, this is my personal advice. If you can say, I am doing well, I am exercising every day, I'm watching my diet, and I want to get a boost to my weight loss because I've already established the right things that are going to keep me going once I start paying money for this drug. My advice is put the cart in front of put the cart first. You want to get your lifestyle issues going. You want to say to yourself, I am doing the right lifestyle things that I'm going to add this drug as an additional thing to knock these pounds off. And you may not need quite as much of the drug if you have the lifestyle factors going on. And you're going to likely continue to keep that weight off and have the other benefits long term. The benefits for your heart, the benefits for your kidneys, the benefits for your blood sugar and your blood pressure. So that would be the most important thing for you to take away from this from tonight's talk. And anything else you want to discuss? I think
Here, we just got a question that popped in. Would you prescribe a GLP-1 to someone on dialysis, or is this something for people not on dialysis?
I have not heard of them being used on dialysis. And let me tell you something. People on dialysis, unfortunately, lose their muscle mass quickly. And I don't think that, and there is this paradox. People that are overweight tend, and this is old data, and I've looked at the data, haven't looked at current data. And I've seen it in my own experience, so this is anecdotal. People that are overweight tend to live longer on dialysis because dialysis breaks down tissue. It's a catabolic process. Your nutritional state goes down with dialysis. And I, for one, would not recommend losing more weight for dialysis patients. I would not recommend these drugs. Again, there's exceptions to wanting to lose weight to go to surgery as a pre-op kind of condition because some people are too large for even to get operated on. But no, I would not use them in dialysis world.
Yeah, I just posted a comment up there from earlier from Jill, who said her doctor prescribed her, she's on dialysis, and prescribed her, I think she said Mounjaro, and she's a little worried to take that. That kind of falls into what you were just talking about.
I don't know. I mean, like I said, dialysis, we've tried all kinds of ways to improve nutrition in people with kidney disease. And I talked a lot about this in my academic research papers. Dialysis itself is catabolic. It breaks down your tissue. As you age, you're having more of that muscle loss. I don't think it makes any sense to me to focus on that issue when it could be affecting you adversely. Anyway, I'm looking at just someone on lisinopril, metoprolol, okay for the kidneys. I was 46 a long while, kidney, and ordered Renadol. Well, I am not this may be James's thing. I know that there are some nephrologists that think Renadol is worth taking. I will tell you this, if and when, well, not when, my book will be out, I think, for our next show. I think we'll celebrate the launching of my book. And I'll tell you right now, any of you who may have an interest in it, when it goes live, it's going to be available for a week, just for 1 week, at 99 cents.
Ooh.
Yeah, as a teaser, like they do with these drugs, you know. Yeah, so I think that the supplements are discussed at length in my book, and I talk about, and James mentioned fasting, and we'll talk about that. We're going to talk about all kinds of things that are interesting to people with or without kidney disease going forward when I get this next book out. And I sure appreciate those of you who have given me good feedback on my first book. And that's basically why I wrote my second one. You blame it on James and you folks out there. I would never have done this if I didn't get on James' show and he didn't tell me how great my book was, and how you folks who, through this show and other means have told me the same thing. So that's why
Well,
I
I'll tell you,
did it.
I know somebody else who mentioned how great your book was to learn the facts about kidney disease, and that was you. When you listened to the audio version of it, you said, "James, you're right. It is easy to understand," because that was the huge thing. I bought every book out there that I could get my hands on. And a lot of them were like medical books. It felt like reading it. Like, I don't know what they're saying. This makes no sense to me. But yours, crystal clear, easy to understand. I quickly knew, aha, here's what I need to focus on. This doesn't matter. Um, it was like talking to a person, not to some medical expert that thought I had a medical degree. And your second book, for all those out there, I have a preview copy, and let me tell you, the table of contents is massive. All the different things. You have a question about something that, it is probably in there, which is fantastic. And, I'm at that point in my life. I'm planning retirement. I'm hoping for 2031. My kid's out of college. Then I can retire, go move to southern Italy, enjoying the beach and traveling the Mediterranean diet. And I want to be as healthy as I can to go and travel, to see all the sites, to explore history, to touch history. And all those things in your book are very, very important to me. And look, we got lots of cheers from people. Um, they're appreciating it. Now, we are out of time, Dr. Rose. I'll let you finish with one last comment.
Last comment vis-a-vis your comment. I've looked through a bunch of the other books on lifespan and health span, longevity, and a lot of them are way, way, way too deep and scientific. And it's fine for me because I'm a doctor. But I made this book as easy to understand as I possibly could, and hopefully people will agree. And I think next time I'm on, I will have it to show you. I hope.
Yay! Yeah, and Dr. Rose is going to send me the cover of it soon so that I can start promoting it and showing you guys, talking about it on the Dadvice TV Facebook group. All right, we are a bit over our time, and my wife has a husband to-do list for me that I need to work on because we have family coming in for the weekend. My daughter is in a play, and it's her first time being a lead character, and she is singing. She has some solos, and I come from a singing family, so it's gonna be like Niagara Falls for me watching her up there singing. I'm gonna be so happy and so proud of her, and I can't wait for it. But we got to get the house ready for the relatives who are driving up from Cleveland to also see this play. All right. Thank you, Dr. Rowe, for being here. And Dr. Rowe also told me we're going to talk about maybe he'll be here more than once a month. Ooh, that would be awesome. Thank you very much. Thank you, everyone out there. Please like, share the video, comment about that. Helps YouTube know that this is good content and helps them recommend it to other people out there. And that's what we're trying to do. We're trying to spread knowledge and empower people with knowledge to improve their quality of life and live longer. All right, everybody, thank you so much, and I'll see you all in the next video. Bye, everyone.